Welcome back to PCA Deep Dive. While much of our work here in Pennsylvania centers on delegation restoration, scope modernization, and copay reform, our responsibility does not stop at the state line. Federal policy also shapes the health of our profession, the choices available to our patients, and the path seniors are permitted to enter when they need care. Today's episode examines one of the most consequential national efforts currently underway, the Chiropractic Medicare Coverage Modernization Act, H.R. 539 and S. 106. Since we first began developing this episode, the national landscape has changed. The American Chiropractic Association, the International Chiropractors Association, and the Make America Healthy Again Chiropractic Hub have aligned around Medicare modernization. Chiro Congress is also providing resources to help state associations support this effort. That alignment matters. The profession has represented different perspectives over the years, but we now have an opportunity to speak with greater clarity around a shared federal priority. Here in Pennsylvania, former PCA presidents Dr. Dan Schatzberg and Dr. Keith Miller have worked tirelessly alongside the American Chiropractic Association to advance this legislation. Through sustained advocacy and direct engagement, PCA has helped secure support from 16 of Pennsylvania's 17 members of the United States House. That level of support does not happen by accident. It reflects disciplined advocacy, strong relationships, and years of consistent engagement. We are also sharing data and working with Senators John Fetterman and Dave McCormick to build bipartisan support for S. 106 in the United States Senate. This legislation does not add a new category of Medicare benefits. It would allow Medicare beneficiaries to receive existing covered services from doctors of chiropractic when those services fall within their state-authorized scope of practice. But this episode is about more than one bill. It asks what happens when our healthcare system makes symptom management easier to access than comprehensive evaluation, functional restoration, and conservative care. It examines how the first door a patient enters may influence whether care begins with movement, rehabilitation, and self-management, or escalates toward medication, injections, and surgery before conservative options have been fully evaluated. Medication and surgery may be necessary for some patients. The question is whether reimbursement policy should determine that pathway before clinical need does. With that context in mind, let's dive in.
Welcome to today's deep dive. We are jumping right into a pretty fascinating policy issue today. But to set it up, I want you to imagine a specific scenario.
Okay, lay it on me.
So imagine you are driving your car and suddenly the engine starts making this horrible, rhythmic, metallic clunking sound.
Oh, that is the worst sound, just instant panic.
Right. So you do the responsible thing. You take it to a mechanic who has spent their entire professional life studying your exact specific engine.
Makes sense.
You pull into the garage, and the mechanic takes a look and says, "Good news, I can fix this. I'm fully licensed to repair this engine."
Right.
And your insurance will completely cover the repair itself, like the actual turning of the wrench.
Okay, sounds like a win so far.
But then they drop this on you. They say, yeah, but your insurance completely refuses to pay for the inspection or the diagnostic testing required to figure out what is wrong in the first place.
Wait, so they will pay to fix the problem, but they won't pay to pop the hood and actually find the problem?
Exactly. The mechanic tells you, look, you either have to pay for the diagnostic work out of your own pocket, or you have to drive this clunking, dangerous car across town to a general tire shop. Have them look at it, get a note from them, and then drive all the way back here so I can finally pick up my wrench.
I mean, it sounds totally absurd when you put it in the context of a car.
Right. Makes no sense.
But, if you swap the car for a human spine and the mechanic for a doctor of chiropractic, you are looking at the exact reality of Medicare's 1972 rules.
Which is wild.
It is. And we should clarify something really crucial for you right away. Chiropractors are not barred from examining patients. I mean, they are fully licensed portal of entry providers.
Right. They're legally allowed to do it.
Exactly. And Medicare generally covers the actual spinal manipulation. What they simply refuse to cover is the evaluation and management visit, the imaging, diagnostic, rehabilitation, or therapeutic services furnished or ordered by the chiropractor.
So it's almost like telling a homicide detective, hey, you will get a paycheck for making the arrest, but you're forbidden from billing for interviewing witnesses or dusting for fingerprints to figure out who actually committed the crime.
That is a perfect analogy. The provider is perfectly qualified, and they're licensed by their state to do the detective work. But the patient must either pay privately or go obtain those exact same services somewhere else just to get them reimbursed.
So this kind of points us to the massive question at the center of this deep dive.
Mm-hmm.
Does our healthcare system actually restore your function, or does it just manage your next reimbursable symptom?
That is the big question.
Because looking at the research and the policy history today, it is just wild to see how this current Medicare policy reveals a system that makes symptom management significantly easier to access than actual evaluation, functional restoration, and conservative care.
Yeah, and remember, these rules were written in 1972. I mean, think about how much our understanding of musculoskeletal care has evolved since the Nixon administration. Yet we are still forcing modern patients through this totally archaic bureaucratic bottleneck.
Let's bring this down to earth and look at how this impacts a real person. Let's talk about Brenda.
Okay, let's talk about Brenda.
Brenda is 72 years old. She's living on a fixed income, which means every dollar is accounted for.
Very common scenario.
Right. And she wakes up one morning with severe neck pain. But it's not just that she slept funny. This pain is radiating all the way down into her shoulder, her arm, and her thumb.
Right, so clinically, that radiating pain, what we call radiculopathy, is a really significant presentation. It changes the entire approach.
How so?
Well, Brenda needs a careful history and a thorough neurological examination. The doctor needs to check her reflexes, test her dermatomes, evaluate her grip strength.
Because it could be like a minor pinched nerve, or it could be something much more severe.
Precisely. And there's an important nuance here. That radiating symptom does not mean an X-ray or an MRI is automatically required for every single patient.
Oh, okay. So it's not an automatic trigger.
Right. It means that imaging or a specialist referral may be appropriate based on the specific findings and the clinical risks discovered during that initial exam, but the doctor cannot possibly know what she needs until they actually evaluate her.
But because of Medicare's rules, Brenda is facing this totally unfair choice. She trusts her chiropractor. She goes to their office for help.
Right.
But because Medicare won't cover her chiropractor's evaluation and management visit or any imaging they might order to ensure she could be safely treated, she just hits a brick wall.
Yep.
She must either pay privately, which she simply cannot afford on her fixed income, or she has to enter this incredibly time-consuming referral loop.
And that loop is brutal.
She has to go book an appointment with her primary care provider, her PCP, just to get permission to get an X-ray.
Which means she is forced to bounce around the healthcare system, physically driving from office to office while in acute radiating pain.
Wait, let me challenge this for just a second. I mean, if she has to go see her PCP, isn't a second set of eyes a good thing? Like, maybe it's annoying to wait a week for the appointment, but what is the actual harm in having her primary doctor take a look?
It's a fair question. The harm is the fragmentation of her care and the cascade of interventions that often follows. Think about the reality of that delay.
Right.
While Brenda is waiting a week in pain for that PCP appointment and then waiting another 2 weeks for an imaging appointment, how is she coping?
Probably not well.
Right. She is highly likely to be given a prescription to tide her over. And I want to be clear, we are not attacking physicians or medication, imaging, injections, or surgery here.
Right. If she has a massive structural issue, surgery might be exactly what saves her mobility.
Absolutely. Depending on the specific pathology, each of those may be entirely appropriate. The problem isn't the existence of those treatments.
Then what's the issue?
The problem is that this policy chooses the patient's healthcare pathway before clinical need does. Reimbursement makes the medication pathway immediately easier to access than the conservative care pathway.
Just because the PCP visit and the prescription are fully covered with, like, no bureaucratic fiction?
Yes, exactly. There is this profound observation in the health policy literature on this exact dynamic, and it goes like this. We have built a system that will pay to quiet the alarm, but often refuses to reimburse the provider standing closest to the patient for investigating why the alarm is sounding.
Wow. We've built a system that will pay to quiet the alarm, but often refuses to reimburse the provider standing closest to the patient for investigating why the alarm is sounding. That perfectly captures the madness of it.
It really does. It fragments care completely.
Because we are paying for isolated transactions instead of actual health outcomes. The system looks at a spreadsheet, sees the cost of a chiropractic evaluation and management visit, and blocks it to supposedly save money.
Right, but it is completely blind to the massive downstream costs of that fragmentation. And it gives chiropractors the really heavy responsibility of being a portal of entry provider.
Meaning they are legally responsible for catching red flags.
Exactly. They have to diagnose the patient, but the system doesn't actually recognize or reimburse the complex work required to do so.
Which brings us to the whole concept of the first door. I mean, if Medicare policy is essentially placing a toll booth in front of the conservative care door while leaving the medication door wide open, we need to ask what happens when a patient is actually allowed to walk through the conservative door first.
It's a huge factor. The first provider a patient sees completely shapes their healthcare journey. And the data here is striking.
I was looking at this.
Yeah, research consistently associates the chiropractic or conservative care door with significantly lower opioid use, less invasive escalation, and lower surgery rates in some populations.
Okay, let's look at the actual numbers here, because this is where the policy failure becomes glaring for anyone listening. We should flag this for verification because it's so significant.
Go for it.
Patients who receive chiropractic care have a 56% lower risk of filling an opioid prescription compared to those who do not.
It's a massive difference. But, we must always remember in research that association does not prove causation. Going to a chiropractor doesn't magically make opioids disappear from the earth.
Right, it's not magic.
But the trend is undeniable.
And what about the injury data? Because I saw a statistic noting a 76% lower risk of injury for older adults who use chiropractic care compared to seeing a primary care physician for the same musculoskeletal complaint.
Yep, that data is out there.
But how does seeing a medical doctor increase your risk of injury? That sounds completely counterintuitive.
It comes down to the cascading effects of those contrasting pathways we talked about. Think about Brenda at 72 years old.
Okay, the fixed income, the radiating pain.
Right. If she walks through the traditional medical door for back or neck pain, the immediate frictionless tools available are often pharmacological. Strong muscle relaxers or opioids.
Ah, I see where this is going.
Yeah, what happens when you give a 72-year-old a strong muscle relaxer? She gets dizzy, she loses her balance, she falls and breaks a hip.
Oh man, that is the injury cascade.
Exactly. On one hand, you have the conservative pathway, which focuses on evaluation, manual care, exercise, rehabilitation, education, and self-management, and it only escalates to specialists when those fail.
Right.
But on the other hand, the traditional pathway offers immediate access to medication, advanced imaging, injections, specialist referrals, and possible surgery.
And again, we aren't saying the second pathway is inherently wrong or bad.
Not at all. But the standard supported by modern guidelines is really clear. Conservative care first when appropriate, more invasive care when necessary.
Conservative care first when appropriate, more invasive care when necessary. But by restricting access to the conservative evaluation, Medicare is essentially flipping that standard upside down.
It is forcing the invasive care to be the default, simply because it's easier to bill for.
And the sheer volume of clinical evidence backing up conservative care is staggering.
Yeah.
I mean, over 6,000 studies and modern clinical practice guidelines show that spinal manipulation and multimodal chiropractic care are heavily evidence-based options.
For appropriately selected patients with musculoskeletal conditions, notice that key phrase, appropriately selected.
Right, so we aren't making grandiose claims of universal effectiveness.
Exactly. As the literature puts it, the evidence does not tell us chiropractic is the answer for every patient. It tells us chiropractic is a legitimate, evidence-based option for many patients, and Medicare should not obstruct access before the clinical evaluation has occurred.
Right, how can they know if it's the answer if they can't even get evaluated first?
Precisely.
So, if the clinical evidence is screaming for better access, and the current pathway is leading to unnecessary opioids and care fragmentation, how do we actually fix a rule that has been on the books since 1972?
Right. What's the holdup?
Yeah, what is the actual bottleneck in Washington right now?
Well, the vehicle for this change is currently sitting in Congress. It's H.R. 539 in the House and S. 106 in the Senate. It's known as the Chiropractic Medicare Coverage Modernization Act.
Okay.
This legislation would expand Medicare recognition of doctors of chiropractic for covered services that are already authorized under their specific state laws.
Let me stop you there for a second, because the phrasing expand Medicare recognition might sound some alarm bells for people worried about the federal budget.
That's a fair point.
Does this mean chiropractors are trying to become exactly like medical doctors in the eyes of Medicare, or that they're trying to invent a bunch of new, expensive treatments to bill for?
No, not at all. And that distinction is vital. It absolutely does not make chiropractors identical to all physician types, and it does not create entirely new benefits out of thin air.
Okay, so what does it do?
The treatments, the imaging, the evaluation and management visits, Those are already covered Medicare benefits. The bill simply allows Medicare beneficiaries to access those existing covered benefits from their chiropractor, provided the chiropractor is already licensed by their state to perform them.
Okay, that makes total sense. But, looking at the trackers, these bills have a massive amount of bipartisan co-sponsors. So if everyone agrees this is a good idea, why hasn't it been signed into law yet? Is it just a done deal?
Oh, I wish. No, co-sponsorship is just the starting line in Washington. It is definitely not the finish line. We have to separate introduced bill text from the grueling mechanics of actually passing a law.
Right, the whole Schoolhouse Rock process.
Yeah, exactly. You have the introduced bills, which is great, but then you have the negotiation of proposed amendments. For instance, the American Chiropractic Association and the International Chiropractors Association recently reached this historic agreement on how to improve this legislation.
Which, by the way, is a huge deal historically speaking.
It really is.
Those two organizations have debated philosophy and scope for decades. So the fact that they are now completely aligned on making Medicare modernization a unified priority speaks volumes about how urgent this patient access issue is.
It does. But even with that alignment, their proposed amendments still require formal drafting by Legislative Council. Then the bill needs budget scoring by the Congressional Budget Office, the CBO.
And they are notoriously rigid.
Extremely. They will look at the immediate cost of paying for that evaluation and management visit, but their models often struggle to account for the long-term savings, like preventing a $50,000 spinal fusion or an opioid dependency.
Right. They see the short-term cost but miss the long-term savings.
Exactly. And after all that scoring, you still need actual committee action and floor votes.
It's a long road.
Yeah.
But we are also seeing alignment from across the broader political and social spectrum. I mean, you have traditional healthcare reform advocates, you have infrastructure support from Chiro Congress, and even involvement from the Make America Healthy Again movement.
Yes.
And we were reporting this impartially, but it shows a broad realization that the way we are doing things right now just isn't working.
Right, but national alignment and a unified narrative in Washington only get you so far. To actually move the needle, that federal advocacy has to be connected to grassroots, state-level action.
Which points us directly to Pennsylvania as like the perfect proof of concept for how this actually gets done on the ground.
Pennsylvania is absolutely the blueprint right now. The Pennsylvania Chiropractic Association, the PCA, they haven't just been asking for signatures on a federal bill. They have laid massive groundwork connecting this federal push to concrete state reforms.
Because ultimately, state law dictates what a chiropractor is actually allowed to do within that state, right?
Exactly. So the PCA has been advancing delegation restoration under a bill called HB 1106 and scope modernization under SB 1330. By actively connecting federal Medicare access to state-level issues like copay reform, patient access, and conservative care, they show lawmakers how the entire ecosystem is connected.
And the results of that groundwork are pretty incredible. The data shows that PCA's advocacy has helped secure support from 16 of Pennsylvania's 17 members of the United States House.
That is an overwhelming majority of their delegation. And, listeners can verify those exact counts as congressional seats fluctuate, but securing that level of House support requires relentless relationship-based advocacy.
But the House is only half the battle.
Exactly. The PCA is very clear that they now have to explicitly address the need to engage both of Pennsylvania's U.S. senators separately.
Both of them?
Yes, both U.S. senators separately. Moving the companion bill S-106 forward in the Senate requires that exact same level of sustained pressure.
So what does this all mean for you listening right now? It means that just having your representative's name on a bill is not enough. The structural barriers are still there. We are at the final push, and your action is required.
You need to thank those existing cost sponsors, absolutely. But simultaneously, you need to demand hearings and actual committee movement. You have to engage congressional leadership and both of your U.S. senators. Right. Participate in advocacy days and support the PCA's efforts on the ground.
And crucially, you need to share your patient stories. I mean, when you talk to a lawmaker, they deal in spreadsheets and budgets all day.
They do.
You have to document the real-world referral delays for them, show them the care fragmentation, tell them about the painful out-of-pocket costs this 1972 policy is causing today.
Policymakers need to see that this isn't about billing codes. It's about people like Brenda who are being denied the conservative care they need. The core of the advocacy position is summarized perfectly here.
Let's hear it.
We are not asking Medicare to guarantee chiropractic care for every condition. We are asking Medicare to stop placing unnecessary barriers between patients and qualified doctors providing covered services within their licensed scope.
We are not asking Medicare to guarantee chiropractic care for every condition. We are asking Medicare to start placing unnecessary barriers between patients and qualified doctors providing covered services within their licensed scope.
Yeah,
It's truly that simple. Stop putting up barriers to the providers who are actually trained to help.
it really is. But before we wrap up today, I want to leave you with one final kind of provocative thought to mull over, something that builds on this entire discussion.
Okay, I'm intrigued.
We are currently watching the rapid rise of artificial intelligence and these complex value-based care algorithms in modern medicine.
Right, everyone is talking about AI.
Yeah, and these algorithms are designed to look at millions of data points and tell us what the standard of care should be.
They train on massive oceans of claims data to predict the best outcomes.
But think about what data we are actually feeding them. If our massive data systems continue to track bureaucratic checkboxes, like whether a PCP referral was signed quickly or whether a prescription was filled on time, instead of tracking whether a senior citizen actually kept their mobility without needing opioids,
Oh, wow.
what is the AI going to learn? Are we measuring true health, or are we just getting incredibly good at measuring our own paperwork?
That is chilling. Because if the system's data is completely blind to the conservative care that actually works, just because it was never reimbursed and therefore never recorded in the claims data, the algorithm is just going to keep recommending the invasive care that costs.
Exactly. It becomes a self-fulfilling prophecy. The data just reflects the bureaucracy, not the patient's actual well-being.
So ask yourself one last time, should your healthcare system be designed to restore your function or just seamlessly manage your next reimbursable symptom? Think about that the next time you or someone you love needs to walk through that first door. Thanks for taking this deep dive with us.
Thank you for listening. The growing national alignment around Medicare modernization represents meaningful progress, but an agreement among organizations is not the same as enacted law. H.R. 539 and S-106 still require committee movement, congressional action, and sustained engagement from doctors, patients, and state associations. Because sponsorship matters, but it is not the finish line. The Chiropractic Medicare Coverage Modernization Act represents more than a technical correction to reimbursement policy. It is an opportunity to align Medicare with modern clinical practice and give seniors better access to existing covered services from qualified doctors practicing within their licensed scope. This is not chiropractic versus medicine. Medication, imaging, injections, specialist care, and surgery all have an appropriate place when clinically necessary. The principle is simpler. Conservative care first when appropriate, more invasive care when necessary. For many appropriately selected patients, the chiropractic door begins with evaluation, movement, manual care, exercise, education, and self-management. And it may end there without escalation to injections or surgery. When escalation is necessary, conservative care can help determine when that next door should be opened. Research has repeatedly recognized chiropractic and spinal manipulation as evidence-based options for appropriately selected patients. It has also associated earlier access to conservative care with lower opioid use and less escalation to invasive treatment in some patient populations. The evidence does not tell us chiropractic is the answer for every patient. It tells us chiropractic is a legitimate option for many patients, and Medicare should not obstruct access before the clinical evaluation has occurred. We are not asking Medicare to guarantee chiropractic care for every condition. We are asking Medicare to stop placing unnecessary barriers between patients and qualified doctors providing covered services within their licensed scope. Please complete the action form included in the show notes and contact your federal elected officials. Ask them to support and advance H.R. 539 and S-106. If your member of Congress is already a co-sponsor, thank them and ask them to help move the legislation through committee. Contact Senators John Fetterman and Dave McCormick and ask them to support Medicare modernization in the Senate. Share patient stories, document referral delays and unnecessary out-of-pocket costs. Participate in PCA advocacy efforts. Join us in Harrisburg. Support the PCA PAC so we can continue protecting and advancing chiropractic rights in Pennsylvania. Defending our profession and improving patient access cannot remain the responsibility of a few. It requires all of us to remain informed, organized, engaged, and visible. Stay informed, stay engaged, stay grounded in the evidence. Policy does not change simply because the argument is logical. It changes when the profession is informed, organized, visible, and willing to act together.